Well, good afternoon, colleagues and officials. Welcome to the Standing Committee on Human Services. My name is Ken Cheveldayoff. I'm the MLA for Saskatoon-Willow Grove. And welcome committee members. Ms. Mira Conway is a committee member, but substituting in for her is Ms. Vicky Mowat. Welcome. Mr. Ryan Domitar, Mr. Mohammed Fayez, Mr. Derek Myers, Mr. Hugh Nerline, and Ms. Alana Ross. Today, the committee will be considering the estimates and supplementary estimates for number 2 for the Ministry of Health. Then we'll take a brief recess and return to consider the estimates for the Ministry of Social Services this evening. We will now begin with Vote 32, Health, Central Management and Services, subvote HE01. Ministers Merriman and Hindley are here with their officials. I would ask that officials please state their names before speaking at the microphone. As a reminder, please do not touch the microphones. The Hansard operator will turn on your microphone when you are speaking to the committee. I would ask officials not seated at the table who wish to speak to take a place at the table prior to speaking, if possible. Ministers, please introduce your officials and make your opening remarks. Just before you do, we have a new rule in place here. I just want to remind members that we are scheduled to go till 5:15. If for any reason we adjourn earlier, it'll be deemed 2 hours of time. So I believe the House leaders have made that agreement, and I was asked to put that on the table here. Without further ado, Minister Merriman.
Thank you very much, and committee members. I'm pleased to have this opportunity to speak about the Ministry of Health's budget. The ministry's senior leaders that are joining me today are Max Hendricks, I have Denise Maxa, Mark Wyatt, Billy Joe Morissette, and a team of others that will introduce themselves as needed, Mr. Chair. I also acknowledge the senior officials here today from the Ministry of Health and will ask them to introduce themselves. I'd like to begin by saying that Saskatchewan is back on track with vastly improved financial picture and fiscal plan to return the budget to balance, as you've heard the Minister of Finance address in her speech. We have much to be optimistic about in the approaching year and look forward to seeing the results of what we set out to achieve. Saskatchewan's residents and healthcare workers face difficult circumstances during the COVID-19 pandemic. I'd like to express my sincere gratitude to the healthcare workers for providing a safe, compassionate care during these difficult times. With vaccinations and available treatments, we have a brighter path forward, and we can move ahead to address other demands as part of our rebuilding process. The Saskatchewan government is making a record investment in healthcare this year to address surgical wait times, mental health, and many other priorities. As we focused on our healthcare resources on the pandemic over the past 2 years, it limited our ability to deliver health services in some other areas, but not limited to the number of surgeries performed. This year's budget will address many of those priorities and get our healthcare system back on track. The 22-23 Ministry of Health budget provides an increase of $318.7 million or 5.2% from the 2021-22 budget for a total of $6.44 billion, which represents the largest health investment in Saskatchewan's history. The Saskatchewan Health Authority, Saskatchewan Cancer Agency, and eHealth Saskatchewan will receive the largest budgets ever. This budget provides substantial funding for acute and emergency care in urban, rural, and northern communities, key provincial infrastructure investments, and will protect people as we adjust to living with COVID-19. It also provides record investment in mental health and addictions and cancer treatments and programs. My colleague, the Honourable Everett Hindley, will speak to more details of mental health and addictions initiatives, as well as for those seniors and rural and remote health. Our government recognizes that workers who deliver patient care are the foundation of our healthcare system. This budget will support development of new and innovative solutions to invest in Saskatchewan's valued healthcare providers and build a more robust workforce. Planning work has begun to establish a new independent agency dedicated to recruitment and retention of healthcare professionals. The Saskatchewan Healthcare Recruitment Agency, or the SHRA, will serve to attract the best and the brightest from across our province, North America, and around the world to join our friendly and welcoming communities. The 2022-23 budget includes $1.5 million in new one-time funding for recruitment incentive programs. This funding is part of a recruitment mission to the Philippines to attract qualified candidates for hard-to-fill critical health sector positions. To further attract and retain specialists and physicians, $3.5 million in new funding will increase the number of specialty and family medicine resident training seats, expand intake for the Saskatchewan International Physician Practice Assessment, or the SIPA program, and enhance our rural practices initiatives for physicians. Also, an increase of $5.2 million in new funding is provided for physician contracts to assist with the recruitment and the retention process. Key commitments of the 22-23 budget will see significant expansion in acute and emergency services areas within urban and rural communities. A $21.6 million increase is specifically dedicated to reduce the surgical wait list by performing thousands of additional procedures in the upcoming fiscal year. In prioritizing surgical plans and setting aggressive but achievable targets, Saskatchewan will deliver the largest volume of surgical procedures in the history of this province this year. The goal is to reach our total surgical volume of 97,000 procedures in 22-23. This year's investment introduces a 3-year plan to eliminate the COVID-related surgical backlog and return to the pre-COVID wait times by the end of March of 2025. A further $12.5 million investment will support the first of a multi-year strategy to create 31 additional intensive care units, ICU beds, across our province. This year, 11 ICU beds will be added to the provincial system for a total of 90 ICU beds. This is the first step in achieving 110 beds to address the overcapacity issues and high occupancy rates leading to a higher quality of care. In addition, we are providing $3 million to fund 10 high acuity beds at the Regina General Hospital to support capacity expansion. These beds will be used to reduce demands on the ICU and improve patient flow. This budget also includes an increase of $2.2 million for specialized care in the neonatal ICU at Prince Albert's Victoria Hospital. A $4.9 million increase will expand the number of specialized medical imaging procedures, including over 11,000 CT and MRI scans. The budget contains a $2 million increase for 65 additional transcatheter aortic valve insertion, or TAVI, procedures for a total of 120 procedures this year. This budget makes significant investments in other healthcare programs and services. Among them, $16 million to increase for the Saskatchewan Prescription Drug Plan for high-cost drugs, treatment changes, and increased medication use. $1.2 million to increase to support community-based organizations, and $394,000 for 6 additional hospice beds at Wascana Rehab Centre. The Saskatchewan Cancer Agency will receive its largest budget this year at $219.8 million. There will be $15.8 million, or 7.7% increase for the Cancer Agency to improve treatments, services, and resource for cancer patients and to achieve better outcomes. Included in this funding increases are $4.8 million for drugs and other therapies, $2 million to boost and hire more nurses and cancer doctors to support patient and treatment volumes and other investments in frontline services, and $1.75 million in additional investments in screening programs for various cancers, including the initial development of a lung cancer screening program for Northern Saskatchewan. There is also $1.1 million for additional resources and funding to address growing demands in the bone marrow transplant program. This also includes the Cancer Agency's budget this year. Also included in the Cancer Agency budget this year are $674,000 increase for development of provincial chematic antigen receptor T-cell therapy programs and an emergency treatment for select types of cancer. $575,000 increase for community oncology programs, ensuring patients continue to benefit from the treatment of options closer to home, and $389,000 increase for medical oncologists to support the establishment of a new medical oncology residency program in partnership with the College of Medicine. All of these investments will ensure that Saskatchewan residents have timely access to screening programs and health professionals and benefit from the most current effective oncology treatment options. This budget will continue to build a better infrastructure through $156.6 million investments in hospital and healthcare facilities. Among other projects, urgent care centres, Prince Albert Victoria Hospital, and Weyburn General Hospital replacement projects will receive priority funding. $15.2 million has been earmarked for urgent care centres in Regina and Saskatoon for design and construction expenses, as well as site selection activities in Saskatoon. $13.5 million has been allocated for Prince Albert Victoria Hospital to cover the procurement and the design of the stages of the project, and $6 million for Weyburn General Hospital replacement to continue with procurement and design activities. There are also significant funding dedicated to long-term care infrastructure projects. $6.5 million for design and procurement of activities for specialized and standardized long-term care beds in Regina. $5 million for continued progress on the LaRange and Grenfell long-term care facilities. And $200,000 will fund planning needs assessment for the Yorkton Regional Health Centre replacement, and $200,000 each will be dedicated to the Watson and Estevan long-term care replacement to continue planning and assessment work. An additional $750,000 has been allocated for planning, procurement, and the design of the Regina General Hospital Parkade. We're also investing over $50 million in maintenance for priority areas. Our government has invested nearly $2.1 billion since 2007 into capital facilities and equipment to improve the delivery of healthcare across our province. eHealth will receive its highest operating budget ever this year at $135.6 million. This is an increase of $9.8 million or 7.8%. The funding will be used for critical investments in healthcare systems and supporting IT infrastructure, modernization and security. This investment will have a positive impact on patient care, healthcare providers, and healthcare partner organizations. The budget also provides significant dollars to sustain ongoing COVID-19 response and recovery measures. Funding of $95 million will support the cost of PPE supplies, ongoing vaccinations, enhanced infection and prevention in long-term care homes. It will also cover the cost of a total of 58 temporary acute care beds in Regina and Saskatoon. These investments will help protect Saskatchewan people as we continue to live with COVID-19. In conclusion, I want to thank the committee for giving me the opportunity to outline some of the significant initiatives in the 22-23 Ministry of Health budget. Minister Henley will speak to our major budget commitments for mental health and addiction supports, as well as seniors, rural, and remote health. We both look forward to the upcoming year, leading the Ministry of Health and the health partner agencies as we work together to tackle the priorities ahead. I will now turn things over to Minister Henley.
Minister Henley, go ahead.
Thank you, Chair, and to the Minister and members of the committee. I am pleased to be here today to speak about the Ministry of Health's significant budget investment into mental health and addiction services and our plan to support seniors' care and rural health services. I would like to sincerely thank healthcare workers across the province for their incredible efforts and hard work during another challenging year. Thank you to all of our dedicated healthcare teams who are caring for patients each and every day. With the COVID-19 vaccinations and treatments available, there is an optimistic path forward. I look forward to much progress in the year ahead as we address the many other healthcare demands and challenges ahead of us. Saskatchewan is back on track with a budget that invests in important programs and services to strengthen and protect our residents. Investing in mental health and addictions services is a priority for our government. This year's total 2022-23 Ministry of Health budget of $6.44 billion will continue to build on record investments in this area. I am pleased that mental health and addictions will receive $470 million, or 7.3% of our total budget to fund critical initiatives. This key area received a significant increase of $9.5 million, with $8 million for targeted initiatives that provide counseling and treatments for Saskatchewan people, reduce harms associated with substance use, and advance proactive preventative measures, particularly for youth. This is the largest total investment ever to support individuals facing these serious challenges. With this added funding in 2022-23, government has invested over $92 million in targeted initiatives in mental health and addictions since 2018. Included in this year's funding increase is $2.1 million to support the first year of a 3-year commitment to add 150 new addiction treatment spaces. This was a commitment introduced by our government in the 2021 speech from the throne, and we are pleased to continue carrying these ambitious plans forward. Our government plans to continue building on support for several important initiatives that have demonstrated success this past year. For example, we will expand on the success seen in the mental health capacity building program in schools throughout the province with a new $800,000 investment, bringing our annual commitment to $2 million to this program. We will also support ongoing work to establish an integrated services model to better coordinate available mental health and addictions services for children and youth. This budget includes $3.4 million for this important priority, up from $2 million in 21-22. A $1.5 million increase to support the continued implementation of initiatives first introduced and committed to in the 2021-22 budget, including our wellness buses. Other annualized funding will support the virtual rural police and crisis team, the PACT partnership with the RCMP, which began as a pilot in 2020-21. In 2021, Saskatchewan experienced a record high number of drug overdoses. We are not alone. Many other jurisdictions across Canada and North America suffered a similar path with tragic outcomes due to substance use. There is an urgent need to address addictions and overdoses in our province, and we are committed to finding solutions. This is not just a health, police, or mental health issue. It will take everyone working together to address it. That's why our government assembled a Saskatchewan Drug Task Force to engage closely with Saskatchewan communities and find solutions to the challenging and complex issues surrounding substance use and overdoses. The 2022-23 budget will fund recent recommendations and priorities released by the Saskatchewan Drug Task Force after extensive consultations with a wide range of partners, including what we believe to be vital input from people with lived experience. These individuals brought an abundance of insight and value to the discussion table. As a result, investments in response to the Drug Task Force consultations totaled $1 million, including $650,000 for development of local integrated overdose response projects, also known as hotspotting initiatives. Funding of $150,000 will go directly towards targeted stigma reduction efforts. A further $150,000 will be used for trauma-informed practice training for frontline staff. This will assist in identifying and appropriately responding to individuals who use substances due to past trauma. And another $50,000 will be dedicated to coordinated research in areas of interest for the Drug Task Force. Of the targeted $8 million increase announced this year, government will invest $475,000 to support the operation of addictional detox treatment spaces across the province. Details around the location of the additional 150 addictions treatment spaces that I mentioned earlier, along with plans for the added detox spaces, are still being determined. Prior to the release of this year's budget, our government provided an update on the continuing expansion of public access to free take-home naloxone kits to help prevent overdose deaths in our province. Take-home naloxone kits are now available at more than 70 pharmacies across Saskatchewan. This year's 2022-23 budget will provide another $200,000 for further expansion of naloxone to community pharmacies. This budget also addresses barriers created by wait times for detox and treatment, while also providing widespread access to harm reduction services and supplies for Saskatchewan people, regardless of where they may live. A $175,000 investment will assist with building capacity and resource development support for recovery from crystal meth addiction. Further targeted investments in mental health supports include $255,000 in new funding for expansion of the Family Services Saskatchewan Rapid Access Counseling Program. Family Services Saskatchewan provides brief counseling services to respond to growing service need. 8 additional communities will be able to offer services as a result of this investment: Moose Jaw, Assiniboia, Gravelbourg, Kindersley, Bigger, Leader, Rosetown, and Unity. This is in addition to 23 communities already served. Finally, the targeted increase will financially support the province-wide implementation of the Mental Health and Addictions Information System with a $1 million investment. This information system improves the quality of care by ensuring clients of mental health and addiction services do not need to continually repeat their story, and professionals can follow and provide more seamless care. In 2021-22, our government introduced a province-wide mental health awareness campaign to address stigma around mental health and directly communicate that your mental health matters. The main message is a simple one that we hope will continue to resonate. There is help, there is hope. An extensive resource list of mental health supports across the province can be found on saskatchewan.ca. We have made progress, but we also know the work must continue. There's a lot more to do in the coming weeks, months, and years ahead, with the end goal of improved mental health and a substantial decrease in opioid or substance use and overdose injuries and deaths. On March 29th, the Advocate for Children and Youth released her special report on mental health and addictions. We thank the Advocate for her work on this very important matter. The mental wellness of our children and youth is more important to me and our government, and we know more needs to be done in this area. We are continuing to review the report and its recommendations in detail, and we'll have more to say in the coming weeks. Upon my initial review, I'm pleased to see that several of the recent investments in children and youth supports align with the Advocate's recommendations. Our increased support for mental health capacity building and the integrated youth services model are 2 examples which build on other investments over the past several years, such as the community recovery teams and the new addictions treatment spaces in Southwest Saskatchewan. Key commitments in the 2022-23 budget will see significant expansion in emergency medical services across our rural communities. To help stabilize emergency medical services, particularly in rural and remote areas, this budget is providing a $10.8 million increase with additional paramedics, ambulances, and funding in 27 communities across the province: Beauval, Beachy, Big River, Blaine Lake, Buffalo Narrows, Cutknife, Frontier, Humboldt, Imperial, Indian Head, Kipling, Kyle, La Ronge, Lloydminster, Macklin, Maple Creek, Meadow Lake, Melfort, Melville, Moosomin, Nacum, North Battleford, Oxbow, Redvers, Rosetown, St. Walburg, and Yorkton. This funding will also support additional training and resourcing for community paramedicine in a number of rural and northern communities. Significant investments into recruitment and retention of healthcare professionals in this budget, which the Minister of Health spoke to in his remarks, will also help get healthcare services in rural Saskatchewan back on track. Seniors' care also remains an important area of focus for our government. A $17 million budget increase will enhance services to help seniors live safely and comfortably in their communities and strengthen long-term care and home care. As part of this funding, $6.5 million will be invested in 117 additional continuing care assistants, 70 for long-term care and 47 for home care. This builds on the 108 added in 2021-22 to a total of 225 of our commitments to add 300 continuing care assistants. There's also funding to assist seniors to remain in their own home or age in place. $2.5 million for improved access to individualized home care funding, and $2.25 million for supportive home care services. We will also be working with our partners to examine ways to better support aging in place and building independence for seniors. We have heard from seniors that they want options to better support them remaining in their own homes. And I'm pleased to be providing $250,000 this year to begin exploring these ideas. This budget includes $3.8 million in increased funding annually for the new expanded Northwest Community Lodge in Meadow Lake. This new 72-bed facility is scheduled to open later this spring. And to better protect seniors against influenza, $4.1 million will be dedicated to deliver high-dose influenza vaccine to all Saskatchewan residents aged 65 years and older. In conclusion, I thank the committee for the opportunity to discuss the significant investments of our 2022-23 Ministry of Health budget. Saskatchewan people and our healthcare workers are determined, hardworking, compassionate, and resilient. We remain committed to support them as best we can. Our officials and I will now be pleased to take any questions that you may have. Thank you very much.
Thank you very much, Minister Hindley. Ms. Mowat, the floor is yours.
Thank you for the opening remarks that provided a little bit more detail on everything that we saw in estimates. And thanks to all the officials who have joined us here today, but are also going to continue joining us as we spend multiple hours looking at health. We know that this is a substantial portion of our provincial budget, and as a result receives a substantial amount of scrutiny. So appreciate your time here today.
Thank you very much, Mr. Chair. And Ms. Mowat, thank you for allowing me to join you. And of course, thank you to the ministers and to the officials for your time and willingness to answer questions. A number of the budgetary choices this year and the impacts of choices in recent years, in the last couple of years, obviously directly related to the COVID-19 pandemic. And with that, the recommendations, the decisions, the role of the Chief Medical Health Officer. And so I'm wondering if we could request, clearly Dr. Shahab wasn't able to join us today, could we request that Dr. Shahab join us for tomorrow's committee?
Thanks for the question, Mr. Miley. I'm not sure of Dr. Shahab's schedule. I don't know where, but we have 25 or 30 officials here that would be able to answer any questions that you have related to the budget.
Would you be able to request whether Dr. Shahab could join us for tomorrow's?
I guess my question would be, are they budgetary questions? Because these sound like they're policy questions.
Definitely related to the ongoing costs, past costs, and the results on ongoing costs within the health system. So yes, very much relevant to budgetary choices.
Thanks. As I've been informed, Dr. Shahab doesn't get involved in our budgetary process. He provides his information to us on public health advice on policy, but is not involved in the budgetary process. That's more at an ADM level, and it's not something that Dr. Shahab has prior to COVID-19 or certainly during COVID-19 been involved in the budgetary process. So if there's budgetary questions involved around public health, we have the officials here that would be able to answer that.
It's quite clear that policy decisions made at the CMHO level and, well, at the Ministry of Health level in response to CMHO recommendations have had, whether those recommendations were followed or not, have had significant impacts on the budget. And the rationale behind the choices made by the ministry thus has a significant impact on the budget. So the request stands to have Dr. Shahab join us tomorrow. In the meantime, a number of written recommendations were made by Dr. Shahab over the last 2 years. If you could tell us more about that process, to whom were those recommendations delivered, and could those written recommendations be tabled, as clearly they would have had significant impact on policy and ultimately on cost within the health system?
Could you give me a line item reference that you're referring to?
A line item reference?
Every line item that we are here to talk about, these are estimates for our budget.
$1 million for ongoing COVID response. We certainly are looking at the past expenditures as well in terms of the added costs. So clearly would apply quite globally to the conversation around health budgeting, not to mention the ongoing impacts of surgical shutdowns, the diversion of care away from things like imaging, et cetera. The list goes on, Minister.
Thanks, Mr. Miley. Dr. Shahab's recommendations do not involve the 2020 through 23 budget, as I've explained. He discusses policy and provides recommendations on public health issues, as I'm sure you're well aware of. These are not necessarily budgetary implications. The budgetary request for the additional dollars for COVID-19 came from the officials that are right here in front of you.
Thank you. The Minister, of course, is aware that those recommendations have had and the decision on whether or not to follow them have had massive impacts on the budgetary choices to date and those going forward. But let's continue. Other things that will have great impact going forward are whether or not we're facing significant future pressures from COVID-19. One of the ways that we have attempted to predict such pressures has been around modeling. Does modeling for COVID-19 cases, hospitalizations, and deaths, is that continuing at the ministry or within the SHA? And if so, what does the current modeling say based on what we're seeing with rising sixth wave cases nationwide?
Thanks for the question, Mr. Miley. The $95 million that you were referring to, I can go through kind of a breakdown of what that entails. And as I've been informed, our modeling group has been extended out until March of 2023, so that would include in this fiscal year and some of that $95 million. $5 million increase from 2021, which obviously we had $90 million. We're maintaining a 6-month supply of PPE, resourcing of 58 temporary acute beds in Regina and Saskatoon. The funding will be prioritized to the most pressing requirements, including compensation, vaccinations, boosters, also within our long-term care facilities to make sure that they are covered off. But modeling would be something that would be included in on that. And we've used that as Dr. Shahab has to inform his decisions in the past, and I assume that he will do that on an ongoing basis when he gets his weekly EPI reports to be able to inform us on what could potentially be happening in the future.
Thank you. Switching back and forth here. Thank you for providing a bit of detail on the COVID dollars. Just noting the fact that we've had a couple of sets of supplementary estimates in health this year, meaning that there were unforeseen costs, pressures to the system. How can we be assured that this is going to be enough for the upcoming year in terms of our handling of COVID-19 and the pressures to the health system? Have those pressures been taken into account? Are there confidence that these numbers are going to be able to get us there, or shall we expect, additional supplementary estimates?
To answer your question on what is going to happen in the 12 months coming up as far as COVID-19, I can't tell you because I don't know, and there's lots of people that are making projections one way or the other. We've allocated, last year we allocated $90 million, and we had to come back for supplemental estimates to be able to make sure that we were covering our costs. We've allocated $95 million this year. If there is a need for an expenditure beyond that, then obviously we go through the supplemental process, but I can't give you a guarantee. These are our budgetary numbers that we work with, that we create in January. And as I've mentioned before, to be able to say what could happen in November globally or in Saskatchewan, it's almost impossible to project for that, but we have allocated money. If this money isn't being used, and I believe I said this last year, if we don't use this money, then we can allocate it in other areas within our healthcare system to be able to shore up that. But this is a budget, and it's not a guarantee. That's why it's a fluid document, and we do have to sometimes come back in health, often come back for supplemental estimates because some of the costs that are incurred were unforeseen at the time of budget.
90 million, and this is 95. What was actually spent on COVID and health last year?
Max Hendricks, Deputy Minister. So in 21-22, the original budget appropriation was $90 million, and we received supplementary estimates of $220 million and a special warrant of $347 million as well. There were allocations to eHealth of $4 million into the Ministry for our pharmacy vaccination program of $15 million, so $366 million. Some of those expenditures, we haven't completed Volume 1 and Volume 2 of our public accounts for last year, so those are budgeted still or supplementary estimates. We won't know until the actual bills come in, but I think our our forecasts are predicting that we'll be in that range.
So just to clarify, you're saying 90 plus 220 plus 347 million is the total. I'm not able to do quick math. So that's the total amount that was spent on COVID in 2021? Estimates, without having the firm actual numbers yet?
Yes.
Okay.
360.
Okay. 366?
At the ministry, so 347 plus 4 plus 15 is 366.
Okay, but just for COVID? Mm-hmm. Okay. Thank you.
Returning to the question around modeling, of course, the minister is correct, so we cannot know the future. I suppose we can plan for it. What, if anything, would trigger, and knowing how costly past waves have been as a result of failing to act soon enough, what would trigger a return to a number of different things? More frequent reporting, so returning to daily reporting. What would trigger a return to wider availability of testing? What would trigger a return to public health measures? Has that been foreseen?
So
Thanks for the question, Mr. Miley. It's as we went through 2020 and 2021, every time that we experienced something changing within COVID-19, we would learn from it and adapt. We engaged the SPSA. We had our POC meetings that are on a daily basis. Sometimes we put as much out in the media as we possibly could. Are there specific metrics to be able to say when we do this, that this will happen? Everything is fluid, and we always sit down and have a discussion with our health providers, obviously with Dr. Shahab, and we able to make that assessment like we have done in the past, and we'll continue to do that in the future. The money that is allocated for this, $95 million, is for the items that I have outlined before. And if there is a need for us to go back and because of a public policy decision that we need to allocate more money than that, then we go through the process of Treasury Board and bring that through to supplemental estimates if need be. We're hopeful that now that we have a very high vaccination rate on our first and second dose and hopefully increasing our booster shot and potentially getting into fourth or second booster shots, as I've been told now, if that's where we need to go to be able to manage through COVID-19, then we'll continue to do that. What we've learned over the last 2 years, we've adapted people, we've moved people around within our healthcare system. So if we need to do that, we will. We've learned from what has happened in the past, and I think our healthcare system is more nimble because of the adaptation that the people on the front line have been able to do over the last couple of years.
To sort of wrap up the question, what you're saying is that at this time you haven't identified what those levels would be, what those thresholds would be, but that should things get bad enough, we might see a return to previous steps, say mask use or more regular reporting or more widely available testing.
Well, again, as you identified yourself, it's hard to predict what's happening if there's different variants that come. As we're seeing the variant that we're dealing with right here and now, I'm feeling very comfortable that the people of Saskatchewan have the tools and the knowledge to be able to manage and live with COVID-19. if something changes in the future and there are things happening around the world and across our country that we need to adapt our behavior in Saskatchewan, then we'll take that under consideration at the time. But I think it would be irresponsible to make a premature assumption on what's going to happen 6 months from now. We're prepared for what could be coming, but to make an assumption of something's going to happen a certain amount of time from now, and us to be making a decision today on information that we don't have, that's not how we've managed this in the past, and that's not how we'll manage it in the future.
Failing to lay out those algorithms and knowing what happens if. That's pretty normal planning. It's been a disappointing element of the response throughout. One of those very obvious things that you've just mentioned that will happen most likely is that we'll see another round of boosters. Has a plan for both the delivery and the payment of a new round of boosters, second round of boosters, been built into that 95 million? Is it built into the budget already, or will that likely be an additional unplanned for expense?
As I outlined when I said the $95 million funding, I'll read it into the record again. Funding will be prioritized for the most pressing requirements, including compensation, vaccinations, boosters, and support of third-party long-term care homes. So as I mentioned before, boosters are included in that $95 million.
Full, should NACI recommendations, for example, say that we're going to full population, as has been the recommendation for the first booster, that's built into the budget that we would have a full campaign?
I'm sorry, you're asking?
Example, like we have with the current booster program.
To wait, I can't budget for something that NACI hasn't recommended yet.
Of course, you can budget ahead, but we'll move on to the next question. Public health, we did not see any additional dollars to public health at the Public Health Department at the onset of the COVID-19 pandemic. In this budget, do we see any dedicated dollars to increasing capacity, be it in testing and tracing, be it in immunizations for other illnesses, any added dollars to the public health budget?
So in public health, we've budgeted $4 million additional dollars for high-dose influenza vaccine to provide it to 65 plus in the community rather than just in long-term care. In terms of some of the monitoring and testing and that sort of thing, we have budgeted for that in the COVID-19 dollars. We're still going to continue surveillance and monitoring the epidemiology, but as part of our regular course of business in public health, we monitor the epidemiology of other diseases and track that, be it influenza, whatever, as it comes on. So the $4 million, though, is, as I said, is targeted specifically at the influenza high-dose vaccines.
or influenza, but otherwise public health is status quo.
Other than public health dollars that would flow towards supporting COVID.
Directly for COVID, but say health promotion, prevention, other standard immunization, no major changes there.
Changes.
Okay. Just while we're on that topic of immunization, we've seen a disturbing rise in anti-vaccine sentiment, particularly around the COVID-19 vaccine, but one worries and wonders both about the spread of that type of thinking and its application to other vaccines, but also the lack of capacity within public health. As you say, we haven't seen a substantial increase, and yet we've had a substantial increase in demand. So what are we seeing in terms of trends for, say, things like standard battery of childhood immunizations, MMR, diphtheria, pertussis, as well as other adult vaccinations that are required?
Our targets for provincial vaccination are to achieve on-time pertussis immunization of 1 dose in 90% of infants aged 91 days, up-to-date measles immunization coverage of 1 dose in 90% of children by their second birthday, and up-to-date measles immunization of 2 doses by 90% by their 5th birthday. Right now in 2021, we were 85% for infants at 91 days, 87% for toddlers 2 years receiving their measles vaccination, and 88% turning 5 years in 2021 had received their 2 doses, so slightly below the targets that were being set.
Compared to previous years in terms of were we reaching targets in previous years? Is this a drop, or is this consistent with previous years?
We don't have the previous year's data with us. This is what we have right now. We can get that though.
So just put on the record requesting those previous years as well as the current numbers. Thank you very much. While we're talking about cost in the system, I'll just back up a little bit. Yeah, if we could have the last 5 years, that would be the best comparator. Thank you very much. Just looking at some of what we've heard today, the budgeted 90 million turned out to be 366, so substantially more. Does the department do any sort of backward-looking analysis of what the added costs were based on outcomes? So since we saw, for example, some of the very high rates, in particular in the 4th wave of COVID-19, high rates of hospitalizations, any comparison to what the national average or what expected costs were versus what the actual outcome was?
That would be a bit of a challenge because every jurisdiction does a budgetary process differently. They might not allocate it and just do it as an extra cost. They might allocate for money just go into the general of healthcare. Everybody budgets it a little differently, so I don't know if we'd be able to draw a straight apples to apples comparison on that. But I know that there were most of the governments did have to go back for additional dollars because depending on when their budget cycle also is, when last year we were planning for COVID-19, we were looking at the immunization of the first 2 shots to be able to get that. That was the focus in January, February, March of last year, was very much the focus of getting 2 shots into everybody and trying to get as many people vaccinated as possible, and that was the main focus of it. And there certainly wasn't, when we were budgeting, there wasn't that obviously that foresight to see what was going to happen in the fall. And again, that's why we're saying that if there are extra dollars needed, we go back for those extra dollars. That's why we have the supplementary estimate process. But again, it's hard to project what's going to happen 3 to 6 months from now with COVID-19. If one thing has taught me about COVID-19 is it is unpredictable and it doesn't follow a very straight line. So.
Very not straight lines. One of the things that was unique to Saskatchewan and a definitely added cost that might have been avoided with better forethought was the requirement to ship patients to Ontario for ICU care when our ICUs were overwhelmed. Could we know exactly how much that cost, in particular the cost of care to the care of those patients when they were in Ontario hospitals, the cost of their flights away and return, as well as the costs to families, any costs that families were required to bear?
We're going to have Mark Wyatt go through it. Just for the record and clarification is the family costs component out of that would have actually come out of a different ministry, would have come out of the SPSA, so that might be a question for that specific file. We don't have that information, but we do have the costs for transportation, and we do have the costs for the stay in the Ontario hospitals, and Mark will get into that.
So, Mark Wyatt, Assistant Deputy Minister. So first of all, looking at the costs that we've been invoiced for by Ontario, as of March 31st of this year, Ontario submitted invoices for 24 out of 27 patients that were transferred from Saskatchewan to Ontario ICUs. And the total cost for the 24 invoiced patients thus far is $837,000. In addition, we have transportation costs for the patients, and as mentioned, this doesn't include SPSA costs for additional family members. And the full cost for the 4 different providers who are providing air medevac service is $1.203 million, $1,203,000.
Okay, so about a little over $2 million total in what you've got calculated. Sounds like all the flights have been invoiced, just waiting on some of the invoicing for the care while in Ontario?
So that's correct.
Okay, excellent. Thank you very much, Mr. Wyatt. Just one more question on the budgeting going forward. Hearing lots of concern about the notion of long COVID, people who might be having ongoing effects from a previous COVID-19 infection. Is there any work underway to plan for additional costs to the health system due to longer-term effects of COVID-19?
So we have started to, well, we started a while ago to do some planning on what it would be, what it will involve to clinically manage patients with long COVID. You know, the majority of patients do see a total absence of symptoms within 2 to 4 weeks, but some people are dragging out, and I think, you know, we're still looking at the research, you know, to understand what that fully means. You know, the presentations of that as well, whether there's any difference in terms of the variant that you caught and the impact and the duration of that impact. But we plan on dealing it primarily through primary care clinicians would be the first point of contact. And what we need to do there is provide education to primary care physicians on recognizing the signs of long COVID and educating them on how to make the referrals, if necessary, to the appropriate type of provider. Some might require, physical therapy, that sort of thing. And so we would educate them on recognizing it, and with a patient that had COVID, and then the appropriate steps to take. And also, I guess, just working with the SHA on making sure that those resources are available to support the treatment of that condition.
Dedicated budget at this time, but some consideration being given to how to prepare providers with responding.
I think initially, one or two other provinces have set up a clinic or two in large centers with million-plus populations, and I think for our situation, in most jurisdictions, I think the plan is to use primary care as kind of the initial entry point, and provide the appropriate referrals if necessary from there. I think the majority of this will, a lot of it is time, right? And so a lot of it will be able to be managed by primary care physicians, but in some cases there will need to be some referrals and additional studies.
Speaking a bit about education there of physicians, looking to education of the public, how much was spent in public education campaigns around COVID-19, be it prevention, be it vaccination, in 2020 and 2021, and how much is budgeted for the year ahead?
Thanks for the question, Mr. Miley. As within our healthcare budget, I have a total number here of expenditures for education, advertising, however, is $2.285 million for 21-22. This would have included vaccinations, any mail-out material, everything associated with that. That would not include, as a government-wide, what we were doing through Exec Council, through the Premier's office, through advertising, through our caucus office. There would have been some more expenditures on that side of things. But one of the challenges that we had, and I think we all had as leaders in our community, was battling misinformation. And there was volumes of misinformation flowing around the internet, on social media, sometimes in mainstream media. There was a huge amount. And so it was very challenging to combat that, because the misinformation traveled, from what I saw, about 10 times faster than factual information. So one of the things that we did, not just in our media placements and that, but we were also advertising, or not advertising, but educating our clinicians and giving them fee codes for them to be able to sit down and have that conversation about vaccinations with their patients, be able to provide those vaccinations within their office. But the majority of this was done in the 21-22 budget because we didn't have the vaccinations we didn't get them until December of 2020 and barely started with our seniors at the beginning of 21 calendar year. So the majority of the vaccination information and education we would have had would have been in this current fiscal year. And again, it was a challenge battling misinformation because it was moving pretty quick. But through our physicians, our clinicians, through the ministry, we tried to battle that as much as we can, and also through other areas of government and through local MLA offices as well on both sides of the house. We're trying to battle the misinformation about vaccinations and about COVID in general.
22-23 budget?
That would be included in the $95 million that we've allocated for COVID-19. And again, if there's money that we need on top of that, then we go through our process, which I previously explained.
Okay. I want to look at some of the COVID-19 impacts, starting with schools. I wonder if officials can tell us how many total school outbreaks we have had, how many current school outbreaks we're dealing with, and whether or not we track from those outbreaks the hospitalizations and deaths related to those who have contracted COVID-19 through a school outbreak. And if so, of course, what those numbers of hospitalizations and deaths related to school outbreaks would be. Is that
Just so, how many outbreaks were in the last calendar year total?
Since the beginning, how many had for school outbreaks? How many do we have right now? And then the tracking of hospitalizations and deaths related to those outbreaks.
Just to put that in context, there could be one school that could have multiple outbreaks throughout a calendar year, so it might not, the number might be a little misleading, and then total number, okay.
Each of those count as an outbreak for sure.
We don't have the total number of outbreaks within our schools. As you might recall, a while ago, we were asking the schools, once we changed our reporting structure, that they were to self-declare that it wasn't being done through. We would have to get that information through education and see if we can find that and potentially bring that back to the committee, but it might take a little bit of time to be able to compile that. As far as an outbreak at a specific school that transitioned, if that individual got sick and was hospitalized, and we weren't tracking that specifically. No, we didn't track a specific child if they were, because an outbreak, I'm sure you're well aware, is 2 individuals, and whether that goes to 15 and whether they had to seek medical treatment, that wouldn't be tracked back because we wouldn't have the specific child earmarked from the education system to the healthcare system.
Okay, so if you were able to reach out and endeavor to...
There's some, if we can figure out exactly what that number is, but it did change partially throughout this calendar year as well. So.
And understand that there may be some different reporting based on different reporting at different times. That makes sense.
Number to you for sure.
Appreciate that. I'm curious about, and this is, maybe just a thought, but when we do contact testing and tracing, you usually would go back with the infected individual in hospital to try to find out where that happened from, where that came from. So one would hope that within public health, there was some tracking back to the outbreaks to understand the source of who was hospitalized and who died.
Thanks. It would be, we would know how many children were either sought medical attention or were hospitalized, but to trace that back to a specific outbreak, because we don't know whether they actually got, that hospitalization was from the outbreak within the school or it could have been within a family. As we know, a lot of the contact was within family settings. So.
I'll come back to a similar question for the Minister for Seniors in a moment, but I just want to stay on pediatric care. How many total pediatric admissions have we had due to COVID-19 up until whatever point you're current? And also related, we noticed that since the move to weekly reporting, we no longer see NICU or PICU outlined. We only see adult ICU numbers. Is that because there have been no under 18 ICU admissions, or are we missing or misunderstanding the reporting there?
Clarification there, so you're looking for PEDS admissions?
Since the beginning of the pandemic, for pediatric hospitalizations, and then just that question around, since the change to weekly reporting, have we not been admitting kids to NICU, PICU, or are we just no longer reporting that?
Thanks for that. As I've been informed, we have one patient in PICU, but again, I got to ask if we can get back to the budgetary numbers. These are questions that could be asked in question period, written questions. This is not relevant to the budget of 2023 of how many children are in Jim Pattison's Children's Hospital right at this specific moment. As I don't see the relevance of that of our 22-23 budget.
The question I asked how many children have been admitted throughout the pandemic. Obviously, that would have huge budgetary implications. And then I was asking about reporting, whether or not the ongoing reporting. So you're saying there is a child in PICU now. That doesn't show up on the weekly EPI reports. Can you, unless...
It's admitted into, so I
so
don't...
the question is, between January 30th, when that change was made, we haven't seen any reporting of any PICU admissions. I'm asking about how that's being communicated or why that's no longer included in the regular reporting.
And I understand that, but that you're asking a policy question, not a budgetary question for the 22-23 budgetary estimates of this coming fiscal year. That you're talking about EPI reports on a weekly basis, not about budgetary dollars that are being allocated that the opposition has requested time to be able to talk about this budget. You're asking about EPI reports of this week. You're asking EPI reports. We're here to talk about this budget.
Sir, I mean, it's a bit, I don't want to get too political in here, but it's a bit laughable. We can't talk about things going forward and we can't talk about things going past. I don't know what is allowed. We're asking how many pediatric admissions into pediatric care from COVID-19 since the beginning of the pandemic. That obviously has had huge impacts on the budget.
Try to get that information. I do not have that at my fingertips. But if we could focus the questions on the fiscal budget that we are here to talk about, that would certainly, because that's what my staff has prepared for.
Continue to ask questions about the health impacts related to the health budget, of course. This one is for the minister who might have been feeling a little lonely at that end of the desk, or maybe he was happy being ignored for a while, we'll see. Similar to the question around the total number of school outbreaks, and I do appreciate the minister endeavoring to give us that total. How many total long-term care outbreaks have there been? And again, not how many facilities, but how many total outbreaks. And now with this one, it's a lot easier to say, we know where you got it. So how many long-term care hospitalizations have there been? How many long-term care deaths have there been? And if possible, the current number of long-term care outbreaks as well.
Weigh in here and say that, again, we're here to talk about the estimates. And I know I've heard the opposition leader say many times, obviously this has something to do with the budget. I'm just, I'm being quite lenient, I think, and allowing questions from a wide range, but if the member could identify which vote or sub-vote or which line or bring it back to the finances whenever possible, that would be well received. Thank you.
With respect to long-term care outbreaks and the current active outbreak information, as the member will know, is available on the website. Still, we still publicly report that on Saskatchewan.ca. But in terms of the number of outbreaks between the statistics we have from October 2020 to February 2nd of this year, 2022, in long-term care, there have been 217 resolved outbreaks and 50 that are currently active.
Great. And then the subsequent questions around the number of hospitalizations and deaths related to outbreaks in long-term care? Long-term care residents were hospitalized up until whatever date you have reporting. How many long-term care residents are now deceased?
to the member. We don't have the current cumulative total right now. We'll endeavor to try to get that for you. We know that we're just checking back here, and there was a written question, I think, last spring that we've provided some answers to that had that sort of calculation in there specific to long-term care, but we don't have, again, just a cumulative total as of today as to what that number is, so we'll try to track that down for you.
For all of those questions of hospitalizations, deaths, and total outbreaks?
Yes.
Okay, thank you very much.
Yeah.
Related, as we look at the deaths, and I believe it's 1,232 official deaths from COVID-19, are you able to provide a breakdown of those deaths by ethnicity, First Nations and Métis, visible minorities, et cetera, as well as socioeconomic status, or is that information not being tracked?
Mr. Chair, I'd ask again what the relevance of this is to our budgetary estimates that we're doing here right now.
Because I think you should ask me.
If you could define the relevance to the specific estimates and the budget of the question you just asked, it would be appreciated.
So, we spent $366 million on COVID-19 last year. $95 million is budgeted for the year ahead. The arrival of people in hospital and ultimately leaving hospital in the way we don't want them contributes significantly to those associated costs. Understanding who's getting sick, who's winding up in hospital, and who's dying helps us to understand where that money went, as well as to plan forward for, if we're seeing a particular community being affected disproportionately, then you change your behavior to try to decrease both the costs as well as, and I think it's important, Mr. Chair, to remember we're evaluating the dollars being spent, of course, but also the value of those dollars. What outcomes did we achieve by spending them in the right place? So again, the question is around the breakdown of deaths by ethnicity, by socioeconomic status, and any other categories that the ministry has been tracking those impacts.
I'm not seeing the cost of COVID care isn't affected by race or ethnicity or religion or gender.
Intentional there, but the cost is affected by the number of cases. So if you've got First Nations people being affected at 3 times the rate of the rest of the population, I'm making that number up, but you imagine that for a moment, that's going to have a particular cost because you're failing to prevent those cases in that community. How do you then examine the ongoing response to avoid both the health impacts, of course, because that is ultimately the purpose of your health budget, but also the expenses associated with the care?
Well, I think the answer to that is we worked with our First Nation communities, our Indigenous communities. We were the first ones, the first Moderna that we had within our province went up north.
What the numbers were? What's the breakdown? Do you track it or no? That's a simple yes or no answer. And if yes, can you provide it?
Answer, Mr. Chair. Myla.
Yes, absolutely. Yep.
Thank you. We worked with several Indigenous communities going door to door in some areas. We were also working with FSIN, with Saskatoon Tribal Council, in setting up a clinic in Saskatoon, working with other Indigenous communities, Cowessess First Nation in the Regina area, to be able to help out and educate. We had our vaccination information translated into many languages and put out on the airwaves in many languages to be able to make sure that people were included and understood the facts, as we talked about before, battling misinformation. And certainly we always make sure that we're inclusive of everybody within our healthcare system to make sure that they're getting the factual information on COVID-19, but also the factual information and have every opportunity to be able to get vaccinated.
Well, that is a good story. But the question was, do you track deaths and infections on ethnicity, on socioeconomic status, or no? It's a simple yes or no.
No, we don't track that information due to some of the limitations we have within our database, but no, we don't track that. But every person that we've lost from COVID-19 was a significant loss to our community.
I couldn't agree more on the loss. I do not agree that that's not a wise thing to do to analyze that information, have a better understanding of the impacts within our communities. I am also looking at, as we're tracking deaths, we see a significant increase in total deaths that aren't accounted for by the 1,232 official COVID deaths. Excess mortality in Saskatchewan from March 8th to 2020 to October 16, 2021 was 11%. That's nearly twice the national average. From September 21st of 21 to October 16th, the excess mortality was 26%, 5 times higher than the national average. We don't have any further reporting to the Canadian Vital Statistics database after October 16, 21st, so we don't know what happened after that date. But up until that point, 20% of the death reporting since March of 2020 has not been completed. There's a couple of questions there. One, what's going on? Why is Saskatchewan 4 times lower than the national average in terms of, or 4 times more deaths have not been reported to the national database than the national average? But more importantly, there's a large number of excess deaths there, far more than would be accounted for by official COVID numbers. What investigation is the ministry doing to try to understand what those excess deaths are, what the causes might be if the belief is that they do not represent undiagnosed COVID deaths?
Again, Mr. Chair, I'm confused as to how this has to do with a specific line item within our budget. This is not just a general question and answer. This is very specific to our budget. I brought officials here. They prepared for this budget. We've done a lot of work on this budget. If the member has a budgetary question or a line item, I'd be happy to answer that. But I am no longer going to go down this road of him just doing general questions about COVID-19 or whatever else happens to be on his agenda this evening. This is about a budgetary estimate. This is what we've agreed to as House leaders and back and forth. This is what we need to continue to do, is to talk about this budget. This is not an inquiry. This is about budgetary estimates. I would ask that we please stay on topic again.
Thank you, Mr. Minister. I believe we have a point of order. Would the member please state his point of order?
Thank you, Mr. Chair. I would just ask that the member has, in his line of questioning, wandered outside the purview of why we're here, and would like to ask him to get back on track. As we know, there's a lot of people here that are costing the people of Saskatchewan a lot of taxpayers' dollars, and would like to ask if the member could ask his questions as they're relevant to the budget.
Well, if I could just say thank you for your point of order, and I would agree with the point of order, and it'll be well taken. And this is the third time, Mr. Miley, that I will interject and say, can you please specifically point to what area of the budget your question is referring to? Because that's what we're here to do with estimates. As you know, you have an opportunity to ask written questions. You have an opportunity in question period to ask many questions as well. Today, here, we're dealing with the estimates, the financial estimates, and if you could focus on that, I'd be much appreciated. Thank you.
$3.9 billion to the Saskatchewan Health Authority, Mr. Chair. Those dollars are for a purpose. Those dollars are to try to keep people well and alive. If we have an increase in total deaths of 11%, nearly twice the national average, not accounted for, it is really difficult to understand how that's not relevant to the Ministry of Health and the expenditures which are designed to try to keep people well and alive. So again, my question, knowing that we spend these dollars to try to keep people well, knowing that far more of them died than expected, my question to the minister is, what work is going on to understand, because as well, of course, that means more people winding up in hospital, much more expensive. There are significant budgetary impacts of a huge increase in the number of people dying in a given year. So again, what work is going on? What work is going on to try to understand what accounts for those excess deaths, and of course how they might be avoided, knowing that, as well as saving lives being the primary purpose of the Ministry of Health, the dollars that could be saved as well, should we discover what that issue is.
If there's a question about excess deaths or those deaths not being reported in a proper way, I would suggest that you take that up with the Minister of Justice, as that falls under the coroner.
So now looking back, and of course we talk in health estimates every year about waiting lists, extremely important. We saw waiting lists increase drastically for surgeries, approaching 40,000 patients. Not everybody who gets on a waiting list gets that surgery. Some of them don't make it to that point. And I'm wondering if the ministry has numbers on how many people died while waiting for surgery, how many people died on waiting lists that were waiting for organ transplants, as well as any deaths that occurred from those waiting lists while people were waiting for imaging, such as CT scans or MRIs.
Thank you for the question. As was announced in December of last year, we had a very aggressive surgical plan to be able to address the 35,000 plus surgeries that we are aware of within our surgical system that had to be delayed because of COVID-19. We are allocating an extra 7,000 surgeries this year. We're doing another 13,000 surgeries on top of that in 2023, and 18,000 more on top of that on top of the original amount in 2024. We've allocated $21.6 million. This is part of an over $600 million surgical expenditure that we have. We've expanded our ICU beds by 11. We also had our high acuity beds. We've increased them as well as in Regina. We understand that there are some surgeries out there that have been delayed for a long time during the pandemic. As I've said before, I very much appreciate the patience of the people of Saskatchewan. That's why we're increasing our surgical. We also received some money from the federal government that we're going to allocate towards our surgical initiative to be able to get as many surgeries done as possible.
Thank you for the answer, Minister. Just to look back a little bit, though, during that period, up until the present day, from the beginning of the pandemic, how many surgeries were delayed? How many were permanently canceled, so never went on to be performed, removed from the list? And how many people died while waiting for those surgeries? So how many people from waiting lists due to being deceased?
That this is submitted in written questions, and we're endeavoring to gather that information and be able to present it back to the submitter of the written question. So that actually is in process right now.
Today?
I do want to just move on to a couple of other things. I noticed that we're getting close on time here. Did the Ministry of Health or SHA purchase the Lumica platform, the Lumica virtual care platform? And if so, what was the price of that purchase?
So Lumica was the successful proponent in the competition to replace our video conferencing platform, PEXIP, and so we're still in final negotiations with the contract with them, so I can't release a number until those are concluded.
Just to understand, it's not necessarily that the platform is being purchased from Lumica, it's that they will be contracted to provide those services. Just can you, like, are we buying their system, or is Lumica going to be working within Saskatchewan Health Authority?
Yeah, we're licensing the platform for any provider in the province to use, any physician provider.
You are essentially purchasing access for providers to use the platform that Lumica developed.
It's their means to engage in video conferencing with patients, yeah.
Okay. Obviously, when that is finalized, we'll be interested to know what that costs Saskatchewan taxpayers. Might seem a little out of left field, but something else that has been on my mind. We've heard the Premier and ministers saying that we will accept an unlimited number of Ukrainian refugees. That's good news. Obviously, we want to have open arms and open doors. However, the program as it is, these are folks who will not necessarily be refugees as we usually understand them. They may be here on a temporary visa rather than having refugee status. So my questions there, if we're talking about potentially thousands, or even tens of thousands in some of the numbers we've heard, and these are folks who will not have interim federal health or IFH funding through the usual refugee health channels. I guess my two questions: one, will this government provide a similar level of coverage for that first year as we see for federally designated refugees? Two, will we see a significant investment in refugee health provision, for example, the Regina Community Clinic REACH, or perhaps new facilities? And if so, if that IFH type coverage or that investment in added care is going to occur, where would we find that in this year's budget?
Absolutely right, and the Premier has stated, and we had unanimous support of this House to be able to welcome any refugees that are coming from the Ukraine and being displaced by Russia and Vladimir Putin's war. If there are any temporary residents, we will extend them health coverage for the duration of their stay, whether that be a year or if it's further than a year. But this is something that we have to sit down and discuss with the federal government and get their support on. Obviously, they're leading the immigration process. We've opened our doors, but we need to drive this process. The Minister of Immigration and Career Training officials were in contact with my officials to be able to make sure that if refugees did arrive, that they would be able to access our healthcare system, as well as I know the Minister of Education is working on that as well, to be able to access schooling if there's any families that are coming across. This all has to be worked out with the federal government, but as far as our perspective, we are ready to be able to welcome them if they need a temporary card. This is very similar, from what I've been told, as what happened with Syrian refugees when they came to Canada. I believe it was back in 2015, 2016. We offered them a temporary health card so they had access to our healthcare system. We don't know what the amount of the people coming through would be, so it's very tough to provide budgetary numbers for primary health care or what we would know as far as people being able to access, additional people accessing our system. But we'll deal with that on a case-by-case basis. But the short answer is yes, we will make sure that they do have a card, so to speak, and also any interpretation, communications. I know the Ukrainian community has reached out to be able to say that they will help out in any language barriers, and we'll work through them to be able to make sure that any refugees that are coming here from the Ukraine will have health coverage while they are here.
Thank you for that. And as the minister knows, there's health card coverage, you know, what the regular provincial health coverage would be, but as well there's IFH, which some added benefits, pharmaceutical coverage, eye care, etc. Pretty important in that first year when people arrive. That may very well be something that we would want to advocate to the federal government for that coverage to be extended to Ukrainian arrivals, even if it's just on a visa. If that's something the minister wishes to pursue, you'll certainly have our support in doing so.
Requesting from the federal government.
Last question from me. I think we're wrapping up here, but one thing that did jump out at me, the chair will be happy to know, it's in a budget line. Physician services dropped from 636,349 to, a drop of $17,860,000 in physician services. Can you explain that nearly 3% drop in budgeting for physician services?
Understand that's physician services that have gone from fee-for-service to a salaried position or vice versa, and that fluctuates ongoing depending on what the physician's method of billing is.
And can you explain to me what new salary positions or what's leading that shift? We haven't seen a big increase in community clinics or alternate funding plans in primary care. So what are we seeing where people are going from fee-for-service to salary in a pretty substantial way?
I think it's a little bit of a broader question. Depends on the physician, and I may have mentioned this in the House. I know I've mentioned in the media. It's depending on the physician, depending on the circumstances, whether they a fee-for-service can be very good for a community or good for the physician. It could be on a salary. It all depends on what that fit is. So we're trying to make sure that we have good physician coverage across our province, and we have to be flexible with our billing process to be able to adapt to that physician's specific needs in that specific community. So we want to be able to have a suite and different variety for that individual to be able to practice and make it accommodating, because sometimes salary is what they desire, and we want to be able to make sure that we're keeping the physicians content and setting them up to be successful in their either fee-for-service or in their salary, depending on what specifically works best for them. Obviously, we have to look at rural Saskatchewan, we have to look at community clinics in the larger centres, but we also have to make sure that we're meeting the physician's needs on either a fee-for-service or on a salary basis.
I understand you won't have this information at your fingertips, but to provide a breakdown of what we're seeing in terms of number of physicians in salary, number of physicians in fee-for-service, to get a sense of what that shift is, because it's substantial, and it's curious to know just what's going on within physician services.
Make sure the coverage is still the same. It's just a billing process for that. So.
Mr. Minister, Mr. Miley, thank you for the discussion. I will, just in light of where the questions and the discussion are going, I know there's members of the research staff for the opposition watching as well. If I could assist members in asking those questions so they pertain directly to the estimates, it would put the chair not having to intervene as I'd had done 3 or 4 times today. So thank you for the questions. Thank you for the answers. Having reached our agreed time of consideration of these estimates, we will adjourn consideration of the estimates and supplementary estimates number 2 for the Ministry of Health. Thank you.